Assalamu alaikum wa rahmatullahi wa barakatuh. Masa al khair. Good evenings. Our participant, our friend, physician from the Middle East, North Africa. It's our pleasure to run today the 10th MENASO Education Academy Cerebrovascular Grand Round. And today we will have a distinguished speaker from a lovely country, Oman, that will have two distinguished speakers. And Assalamu alaikum, Dr. Saif.
Alaikum assalam.
Hi, Dr. Saif. So no further delay. I'm more than happy today and honored to welcome all guests and participants to the 10th chapter of MENA Stroke Education Academy Cerebrovascular Grand Round 2022, organized by MENA Stroke Organization and endorsed by the American Stroke Association and by the World Stroke Organization. The Cerebrovascular Grand Round Webinar is a unique platform that provides comprehensive education about stroke in the latest treatment and management. The focus for today's webinar will be about neurovascular intervention, which will be delivered by Dr. Saif al-Zaabi and Dr. Ali al-Balushi. Before we start this webinar, I would like to remind all our audience that all the questions can be delivered through the Q&A box at the lower part of the Zoom window that they have. Before we welcome our speakers, I would like to welcome our co-chair, Dr. Abdullah Alsalti, who's a senior neurologist from Oman, head of department and consultant adult neurologist from Khoula Hospital, Oman. Dr. Alsalti did his undergrad training at Sultan Qaboos University and had his membership of Royal College of Physicians, MRCP UK in 2006. Furthermore, Dr. Alsalti did his full neurology residency program at McGill University, Montreal, and then he followed up to do his fellowship at the same institute in neuromuscular disease and EMG. Dr. Alsalti currently is the director and the head of the Omani Neurology Society. Dr. Alsalti is doing other than the neuromuscular disease, headache, stroke, and cerebrovascular disease. Assalamu alaikum, Dr. Abdullah.
Walaikum assalam, Dr. Saif. Thank you for your introduction. Assalamu alaikum, Dr. Saif. تسمعني؟
عليكم السلام Dr. Abdullah. Good to see you at this meeting.
It is my pleasure to be a co-chair with Dr. Saif in dealing with stroke. As Dr. Saif, as Dr. Suhail said, stroke is really one of the most common neurologist disease we have encounters in our duty work. So it is our pleasure to be part of your webinar today.
Thank you. Pleasure is mine. First and foremost, I really thank
Dr. Saif, you want
تفضل سيف كان يبغى يقول شيء.
تفضل سيف تفضل.
First and foremost, I would like to thank you all, especially Prof. Suhail, for giving me my second opportunity to participate in this prestigious ground round. And I'm looking forward to do more, inshallah, in the future. I apologize I didn't have my time to follow both of you in dressing my uniform because I finished late today. So.
Okay, so back to the webinar. Thanks, Dr. Saif. It is our pleasure to be with you, to be honest. So our first speaker is going to be Dr. Ali. Dr. Ali, he did his graduation from United States of America. He did his full neurology program after he finished his residency program in internal medicine here in Oman. Dr. Ali is one of the who did his fellowship later on in vascular neurology, also in USA. Then he did fellowship in interventional neurology also in New York. So he's back with us now in our neurology center in Khoula Hospital for the last 1 to 2 years now. Dr. Ali, he's an add-on to our stroke service and our vascular service. He's really his work is not only doing interventions. He's deal with all vascular neurology related issues. He's one of the excellent neurologists, hard worker in our department. We would like to welcome Dr. Ali to his talk today about cervical artery dissection. Welcome, Dr. Ali. Dr. Ali, he, by the just for the record, Dr. Ali, the talk is going to be recorded, and he will be with us later on for any question later on after the session.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. My name is Dr. Ali Al-Balushi. I'm a stroke neurologist and neurointerventionalist at the Department of Neurology in Khoula Hospital in Oman. First, I would like to thank Professor Suhail Alrukn and the MENA Stroke Organization for inviting me to give this talk. And on behalf of Oman Neurology Society, I would like to briefly discuss the spontaneous cervical artery dissection. I do apologize that I'm not able to make it live, but I have pre-recorded this video for the talk. And please feel free to send me an email with any questions or comments. The scope of this talk would be to discuss the anatomy of the cervical arteries, and then the epidemiology and risk factors of the cervical artery dissection. Then we touch on the clinical presentation, pathophysiology, and natural history. Then we discuss the diagnostic, testing, and management approach. The internal carotid artery originates from the common carotid artery. The first segment of the internal carotid artery is the cervical segment that starts from the bifurcation to the entrance of the artery into the petrous canal, into the petrous bone, where it becomes the petrous segment. If you go and look into the these classification systems, basically the most easy and probably most widely used classification system is the Gibo system. Boethler system is also used, but if you look at the Gibo system, is cervical segment, petrous segment, and then it becomes cavernous segment, and once it's intracranial, it's supraclinoid segment. The Boethler's classification has the cervical segment, petrous segment, lateral segment, and cavernous segment, and there is a small clinoid segment, then beyond which it becomes the ophthalmic and communicating segments, which are the intracranial segments, the ophthalmic and communicating. And the vertebral arteries, there's one vertebral artery in each side. Obviously, the vertebral arteries originate from the subclavian arteries, and the first segment of the vertebral artery is the segment from the origin of the vertebral artery to the entrance into the C6 transverse foramina, and then the V2 segment, or the second segment, from the transverse foramina of the C6 to the transverse foramina of C2, and once it comes out of the C2 transverse foramina, it becomes the V3 segment, or the third segment of the vertebral artery, and which makes a loop and enters into the intracranial compartment to become a V4 segment. The V4 segment joins the contralateral V4 segment to become the basilar artery. On a cross section, the cervical arteries have the tunica intima, which is composed of endothelial layer on an elastic, internal elastic lamina, and then there's a tunica media, which is mainly composed of smooth muscle cells, and there is a tunica adventitia, which is the outermost layer. Intracranial arteries have thin tunica media and tunica adventitia. That's why these, when there's dissection in the intracranial that affects intracranial artery, patient is at risk of having subarachnoid from that dissection. The cervical artery dissections cause about 2.5% of all ischemic strokes, and they represent the etiologic mechanism or the etiologic cause of 20% of ischemic stroke in young, and has the annual incidence of 2.6 to 2.9 per 100,000 for internal carotid arteries and 1 per 100,000 for vertebral arteries. There is a slight male gender predisposition, and the mean age is 45 years. There is a seasonal variation in which the peak is seen in the winter months, and this is likely related to the respiratory infection. The predisposing factors are hypertension, minor or trivial trauma that sometimes patients really don't recall the event. So it's very important to elicit in the history and to ask specifically if there's any history of minor or trivial trauma. Recent infection that we discussed, the upper respiratory tract infection is particularly important. Hyperhomocystinemia, migraine, fibromuscular dysplasia, and obviously genetic syndromes like Marfan or Danlos, autosomal dominant polycystic kidney disease, and osteogenesis imperfecta. These are typically associated with dissections, and one should look in the history and the examination to find any findings suggestive of these syndromes. The clinical presentation of dissection is most commonly patients present with ipsilateral neck pain and headaches. The location of the pain and headaches is really dependent on the artery involved. For example, like in the internal carotid artery, typically the anterolateral part of the neck, or at the angle of the mandible, and also periorbital and also temporal locations of the headaches. The character of the headache could be simple migrainous type headache, or it could be dull headache, or could be thunderclap headache. For patients with vertebral artery dissection, the location of the headache is typically cervical occipital location. Patients with internal carotid artery might have partial Horner syndrome, and obviously if the dissection results in a stroke or retinal ischemia, patients might develop TIAs or infarctions, and that result in, like, in persistent symptoms. Patients might have lower cranial nerve palsies in internal carotid artery dissection because of the close proximity of the lower cranial nerves to the internal carotid arteries. And obviously, if pseudoaneurysm develops, patients may present also with pulsatile tinnitus. This slide shows the location of the headaches and the pain in the dissection, and the yellow color shows the location of headaches in the internal carotid artery dissection, and as you can see, it's periorbital or temporal location, whereas in the vertebral artery, the cervical occipital location is commonly reported. Dissections result from intimal tear or rupture of vasa vasorum in the media. This results in separation of vessel walls and vessel wall layers, leading to false lumen formation, which in turn results in thrombus formation intramurally, which may embolize distally. If the hematoma extends to the adventitia, pseudoaneurysm develops, but if it extends more into subintima, vessel occlusion or narrowing results. This slide shows the pathophysiology of cervical artery dissection, and basically in patients who have genetic predisposition, or sometimes could be just normal patients who don't have any of these genetic syndromes, with the interplay of the risk factors like hypertension, migraine, hyperhomocystinemia, and environmental triggers like minor trauma or neck manipulation, or recent upper respiratory tract infection. This might result in strain on the vessel and dissection, and obviously patients may not have these factors and yet may develop dissection. So about 60 to 70% of patients with dissections may develop ischemic strokes, and the highest risk period for ischemic stroke is within the first 2 weeks. There is some risk that extends up to 4 weeks after dissection, and typically the recurrence rate of the dissection is low. Patients who develop stroke in dissections have different mechanisms for stroke, and basically the most common mechanism is the artery-to-artery thromboembolism. Hypoperfusion due to lumen narrowing is also another mechanism. Vessel occlusion due to subintimal compression and thrombosis is another mechanism. And then obviously some patients might have a combination of these three. And then also, if there is extension of the dissection to the intracranial compartment, occlusion of branch ostium by intimal flap might result also in lack of blood supply, and as a result, stroke from the occlusion of the branch. In this study that was published in 2012 in the Stroke Journal, that included 172 patients, with cervical artery dissection, about 58% had evidence of acute stroke on diffusion weighted images. And the mechanism of stroke was found to be 85% is thromboembolic stroke, and 12% hemodynamic, and 3% is mixed mechanism. On the right-hand side, as you could see, this depicts the presumed thromboembolic mechanism with a cortical infarct and some hemorrhagic conversion. And then if you look at the left-hand side of the screen, this represents the hemodynamic effect with the watershed infarction. The location of the injury in internal carotid artery dissection, typically 2 to 3 centimeter distal to the pulp, and about 17% extend intracranially. So for the vertebral artery dissection, more commonly is the tortuous V3 segment, and also V2 segment may be affected by longitudinal strain. 10% of vertebral artery dissections extend intracranially. The diagnosis is suspected on clinical grounds, but colored Doppler ultrasound has about 70 to 95% sensitivity for detecting ICA dissection, and lower sensitivity, about 75% for detecting vertebral artery dissection. And there are conditions that are associated with increased or decreased flow in the internal carotid artery, obviously confound the diagnosis. One of the limitations of the color Doppler is the sensitivity of vertebral artery is low because of the difficulty visualizing the vertebral artery. This is, you could see in the left-hand side of the screen, this is like the demonstration of the intimal flap on the carotid ultrasound. And similarly on the, like in the color Doppler, you see the flow, color flow of the true lumen versus the false lumen. And then on the lower right side of the screen, you see the demonstration of the pseudoaneurysm. CT angiography has a sensitivity that ranges between 50 to 100% in carotid artery dissection, and specificity that ranges between 70 to 100%. Whereas in vertebral artery dissection, the sensitivity and specificity are quite high, like sensitivity of 100% and specificity of 98%. This, on the left-hand side of the screen, there is a demonstration of the string sign or a very small artery that resulted from dissection of the very small true lumen. Whereas on the right-hand side of the screen, there is a demonstration. This is an sagittal sequence that demonstrates pseudoaneurysm. On this left-hand side of the screen, there is a demonstration of the small true lumen, and then the intramural hematoma, basically surrounding the small lumen. And if you see in 3D reconstruction on the right-hand side of the screen, there is a string sign of the very narrowed vessel, the internal carotid artery. MRI imaging and MRI angiography in the case of carotid artery dissection has a sensitivity of 95% and specificity of 99% for the MRA, and 85% for and 99% for MR imaging. For vertebral artery dissection, the sensitivity and specificity are a little bit lower than internal carotid artery dissection, and that's due to the small size of the vertebral arteries and that difficulty of distinguishing subacute hematoma from normal epidural venous plexus. This is a patient with acute dissection on using T1 weighted image. You'll see there's an ISO intense signal surrounding right internal carotid artery dissection. And obviously in the MRI, the demonstration of the dissection, the intramural hematoma, is dependent on the age of the hematoma, because it basically depends on the breakdown of hemoglobin. Here is an axial fat saturated T1 weighted MRI image, and as you could see in the left-hand side of the screen, there is dissection of the internal carotid artery, and I'm sorry, the right vertebral artery, whereas in the right-hand side of the screen, there is a dissection of the left internal carotid artery, and you could see like the hyperintense signal surrounding a small true lumen. And that's in the subacute phase. This is the MRI image, and you could see in the left-hand side there's a reconstruction image of the internal carotid artery dissection, and that's demonstrated on the right-hand side. And there's a pseudo dilatation of the true lumen on the left internal carotid artery dissection by the compression from the intramural hematoma, and the artery appears a little bit bigger because of the compression. Obviously, digital subtraction angiography is the gold standard testing method in the dissection, and there are different angiographic findings. String sign, flame sign, pseudoaneurysm might be seen as well, and dissection flap also could be seen. These are angiographic images. As you could see, the far left-hand side, you see the string sign, the artery becomes very narrowed and small, and in the second image, you see a flame-shaped, basically narrowing or tapering of the artery, and sometimes you might see flame-shaped with a very small string sign. It's not occluded completely, but in this case, the artery is completely occluded, just in a very flame-shaped tapering. The MSC, you could see the pseudoaneurysm and the internal carotid artery dissection. And in the last image on the right-hand side, you see an intimal flap. So for the management, acute thrombolytic therapy should not be withheld in eligible patients with cervical artery dissection, and we'll go through the evidence. And also the same thing, patients with proximal intracranial occlusion should be treated with endovascular thrombectomy if they are eligible to. The evidence for these statements come from the, obviously we don't have randomized controlled trials to look at, to extrapolate the data from, but we have registries and meta-analysis of individual patients' data. So this study was published in the Stroke Journal and in 2011, and it has basically individual patient data from 14 retrospective series and 22 case reports that involved 180 patients with cervical artery dissection who were treated with IV thrombolysis and were followed for 3 months. As you could see, comparing the cervical artery dissection patients who were treated with IV TPA to the match historic controls, like these are the patients without dissection who were treated with IV TPA, and the endpoint at 3 months. So for mortality, it's actually about similar. Symptomatic ICH is similar, even a bit slightly less in the dissection, but there's no difference statistically. And then for the excellent outcome, the MRS 0 to 1 is basically also the findings are comparable between the match control and cervical artery dissection. For the EVT or endovascular treatment, there's this systematic review that was published in Neurology Journal 2017 that looked at the patients. It's like studies that reported patients with cervical artery dissection with intracranial proximal occlusion who underwent mechanical thrombectomy. And these studies, like 10 out of 16 studies, reported successful TK2P or TK3 reperfusion. That suggests that high technical success. And 11 out of 12 studies described clinical outcome using 90-day MRS's modified ranking scale that showed favorable clinical outcome in these patients. Only one case was reported with the extension of dissection caused by microcatheter, which was treated effectively with stenting. So for secondary prevention, obviously the CADIS trial or antiplatelet therapy versus anticoagulation therapy in cervical artery dissection. This is a trial that looked at that basically aimed to compare the effectiveness of antiplatelet drugs versus warfarin for prevention of recurrent stroke in patients with cervical artery dissection, like cervical carotid and vertebral artery dissection. The norms is within 7 days of onset. This is the primary outcome, as you could see, an intention to treat analysis and also per protocol analysis. For the first, like the outcome at 3 months, there are 3 patients in the antiplatelet group who had ischemic stroke compared to 1 patient in the anticoagulant group. And the same thing is basically on the protocol analysis. And on the TIA, there's only 1 patient on the antiplatelet group and 4 patients in the anticoagulant group. And essentially, there is no difference between the two groups. And also that holds true for the up to 12 months after the onset, and or treatment for basically the bleeding risk was similar between the two groups. There's only one bleeding in the anticoagulant group, and there's obviously this is not significant. So there are no deaths related to dissection in either group. Generally, the conclusion from the CADIS trial was there's an overall small risk of stroke in patients with cervical artery dissection, and the antiplatelet therapy is equivalent to anticoagulation. CADIS has limitations. It's a small sample size. It's not a blinded study, and the antiplatelet therapy was not standardized across the group, like across the participants. So it's up to the treating physician. So about 50%, 55% received single antiplatelet, and 45% received dual antiplatelet therapy. The second randomized control trial was the TREAT-CAD, or aspirin versus anticoagulation cervical artery dissection. And this is a study that aimed at testing whether aspirin is non-inferior to warfarin in the treatment of cervical artery dissection in terms of both safety and efficacy at 90 days, and also MRI at 14 days. So the primary endpoint was the composite clinical and MRI events, and the enrollment is within 2 weeks of onset. This slide shows the results, which basically shows that like a difference of 8% between the aspirin and vitamin K antagonist in terms of the composite of clinical outcomes and MRI outcomes. And then in terms of the stroke outcomes, so ischemic stroke occurred in 7 patients in the aspirin group versus 0 on the vitamin K antagonist. And in terms of the death, there are none. In terms of the MRI outcomes, it happened in 22% in the aspirin group versus 13% in the vitamin K antagonist. Generally, if you look at this slide, basically there's a slight, like aspirin group had a little bit more events than warfarin group. So the conclusions from the TREAT-CAD study was that more patients in the aspirin had clinical and MRI outcomes, but absolute difference of 8%. So aspirin was not shown to be non-inferior to warfarin in composite outcome, clinical and MRI, but also, and we noticed that warfarin was not associated with increased risk of bleeding. However, this study had also several limitations. First, it did not use dual antiplatelet therapy as endpoint and chance-eligible patients. Also, this study included patients with enrollment up to 2 weeks, which is like typically is the highest risk period is 2 weeks, and some patients could have been enrolled by the end of the 2 weeks, like after 10 days or so. Statistical limitation with using large 95% confidence interval interfering with the precision of the outcome difference. And the trial design is for non-inferiority for aspirin, could not also test for the superiority of warfarin. And this trial also used the composite outcome, clinical and MRI outcomes. So the meta-analysis, simple like study level meta-analysis of these two studies, like CADIS and TREAT-CAD, that tested stroke, major hemorrhage, and death in both like combined patient population from the CADIS and from TREAT-CAD, showed no significant difference in the outcome rates between the treatment groups, aspirin versus vitamin K antagonist. The absolute difference was 3%. It was not statistically significant. What about NUAC? So there are no clinical trials that looked at NUAC and dissection, cervical artery dissection, but there is this retrospective study that compared 3 groups. The NUAC, which basically dabigatran, rovaroxaban, and apixaban, versus traditional anticoagulant, warfarin, versus antiplatelet therapy in cervical artery dissection, and a patient with 49 patients. And out of these, like 70% were vertebral artery dissections. NUACs generally were associated with similar rates of recurrent stroke, this 2 versus 1 in anticoagulant and 1 antiplatelet. Fewer hemorrhagic trans complications, NUACs 0%, warfarin was 11%, antiplatelet therapy were 2.5%, but NUACs were associated with greater radiologic worsening numerically, only 3 patients compared to no patients in the antiplatelet or warfarin groups. So the conclusion from this study is that NUACs may be a reasonable alternative in the management of cervical artery dissection. So to conclude, Treatment should be based on the patient's factor for antithrombotics. Patients with intraluminal thrombus and severe luminal narrowing favor anticoagulation, whereas like antiplatelets and vitamin K antagonists and NOAC are all reasonable options in the majority of patients. For the endovascular treatment, patients who have recurrent stroke symptoms despite optimal treatment with antithrombotics, and those with expanding or symptomatic pseudoaneurysm, and patients with significantly compromised cerebral blood flow due to involvement of multiple vessels or poor collateral vessels or both, these patients generally should be considered for endovascular treatment. So the guidelines from American Heart Association, American Stroke Association 2021 recommends class basically it recommends like patients with ischemic stroke or TIA after extracranial carotid artery vertebral artery dissection to be treated with antithrombotic treatment for at least 3 months to prevent stroke or TIA. And there is a recommendation about patients who are less than 3 months from the dissection, cervical artery dissection. It's reasonable to use either aspirin or warfarin to prevent recurrent stroke or TIA. And there is class 2B recommendation for patients with stroke or TIA and extracranial carotid vertebral artery dissection who have recurrent events despite optimal antithrombotic treatment. Endovascular could be considered in these patients. For follow-up, patients would need they will need vascular studies to be performed at 3 and 6 months after the onset of symptoms. And the antithrombotic treatment is typically administered until complete recanalization of the vessel is seen. And long-term or low-dose oral aspirins often administered in patients with dissection and aneurysm to prevent delayed thromboembolic events. The recanalization rates after ICA dissections, in this study, it was a prospective study that included about 250 patients. The estimated rate of recanalization at 1 month was 15%, but at 3 months is 50%, and at 6 and 12 months is like about 60%. So if you look at the graph, so basically once after 6 months, typically there's a plateau of the rate-free recanalization. So obviously in this study it was found that initial occlusion is a poor prognostic factor for recanalization. Whereas in vertebral arteries, there's another study that is a prospective study that looked at the rate of recanalization. It included 61 patients. About 45% of patients recanalized at 3 months and 60% at 6 months and 12 months. So basically essentially the same thing for vertebral arteries. Typically most recanalization will occur by 6 months, and basically beyond that there's a very small chance of recanalization. The prognosis for cervical artery dissection, so typically complete or excellent recovery occurs in 70 to 85% of patients with extracranial dissection, with major disabling deficit in only 10 to 25%, and death in 5 to 10% of cases. And this obviously related to the a number of factors that are associated with poor outcome, like in a high NIH stroke scale at onset, older age, arterial occlusion, and the recurrence rate of dissection is low. It's about like 0.3% per year, and it's associated more with young age and connective tissue diseases. So to conclude, the cervical artery dissections cause about 20% of ischemic stroke in young. The risk of stroke after cervical artery dissection and accompanied by ischemia at the time of diagnosis seems to be limited to the first 2 weeks. Therefore, early detection and management is important. Isolated cervical dissections are not contraindications for hyperacute therapies, and patients should be still considered for IVTPA if they're candidates for, and also thrombectomy if they have proximal large vessel occlusion and they are candidate for thrombectomy. Underlying stroke, understanding stroke patterns and patient-specific factors is the key in guiding secondary stroke prevention, and either antiplatelet or anticoagulant, whichever is selected, it should be started as soon as possible, and the overall prognosis is good in the majority of patients. With that, I conclude my talk, and I appreciate your attention, and thank you for your attention. So if you have any questions, please feel free to send me an email. I'll be very happy to address. Thank you so much.
Thank you, Dr. Ali. We would like to thank Dr. Ali. He will be hopefully, inshallah, with us in the panel by the end of with the next speaker talk. I will leave now the microphone to our Prof, Dr. Suhail Alrukn. Go ahead, Suhail.
Thank you, Dr. Abdullah. Thanks, Dr. Ali, for the nice presentation. Cervical disease and dissection, it's always a challenge to be managed and treated. So we will keep the Q&A till the end. I will ask all the participants to deliver their Q&A questions in the box in their Zoom. أهلا وسهلا Dr. Saif. So our second speaker, Dr. Saif al-Zaabi. Dr. Saif is a consultant intervention radiologist. He at King Fahd Specialist Hospital a few years back. Now he's a consultant senior interventionist at international at Oman, mainly at Khoula Hospital. Is this correct, Dr. Saif?
In fact, actually, I'm directing my own clinic in Muscat, and I have another clinic coming up in Dubai end of this month. And I also have a clinic actually in Saudi. So I'm a freelancer now. I'm actually more on a freelancing type private.
MashaAllah, MashaAllah. Where's in Dubai, Dr. Saif, you will be?
It's going to be in Al Jalila Foundation, where Prof. Suhail knows it very well. It's going to be
Ahlan wa sahlan. So Dr. Al-Zaabi completed his diagnostic radiology residency program and angio intervention fellowship from University of Alberta, Edmonton. He had a practice since that time, full-time interventionist. Previously, Dr. Al-Zaabi was in charge in the academia and admin at King Fahd Hospital in Riyadh, and he was the director for the fellowship in 2013 and the director for the residency training program also for 2 years in the same institute. Then he became the chairman and the director for the medical imaging for 2 years in the same institute. Tonight, Dr. Al-Zaabi is going to tell us about the role of the interventional radiologist physician in acute stroke treatment and algorithm status update. Please, Dr. Al-Zaabi, welcome to the stage.
Thank you so much. I'm just going to pull the presentation here so we can start. Right, you go. All right, so I don't mind being the dessert and missing the big meal. My speech meant to be first one, but I don't mind to be the dessert as well, Abdullah and yeah, so I'm gonna make the talk is sweet and brief. I'm gonna basically focusing on the role of interventional radiologist in participating in the treatment of stroke, as the role has been actually a bit shy over the last few years, although we've seen good pattern change in the practice where interventional radiologists are moving to help in neurointervention, specifically in the endovascular thrombectomy for stroke patients. Now, the best help when you need it is to knock your neighbor door, and neighbor would be available most of the time. And when it comes to helping with the stroke, yes. Oh, I think I missed the slide. Okay, so when it comes to help with the stroke, we look into the standard of care, and the standard of care is the endovascular thrombectomy. And nothing beats taking that clot out of the blood vessel. EVT has been proven very effective and very safe and has been verified on multiple randomized trials and meta-analysis statistical data. It has been also shown to be of a strong evidence at level 1A by almost all international stroke organizations. And it has been increasingly performed over the last few years. We've seen it actually coming up more and more in the primary stroke centers around the globe. Now, it's always about having access to the gold standard treatments, and the question of how could we help these patients getting the access, because clearly there are multiple reasons why stroke patients wouldn't get the gold standard treatment. One of them, which in the focus of this the talk, is the workforce. How could we help having access to angio table where there is more hands to help taking that clot out? If we look at MENA status today, we have really small number of professionals, experts who can perform endovascular thrombectomy for stroke patients. And quite significant number of these patients, of these practitioners, about a third of them are non-neuro IR, which actually knock our doors to open our eyes and say, maybe we could improve this percentage. And maybe if we look even to the non-neuro guys who are actually doing the EVT today, most of them actually self-initiated practice, who are self-trained. They did it with experience, but does that really help getting this number raised up to where we hope to see it, pumped up to at least a third or hopefully half of interventionists in our region can do endovascular thrombectomy for stroke patients? But if that's the dream that we have, that's the target we have, then we have to work on this. And there are a few things that have to be done by everyone involved in the stroke treatment, specifically the societies and leaders. And in order to get more hands on this catheter to pull that clot out, then you have to do basically two main things. First of all, you need to establish a training program, and proctorship have been shown to add a value to this training platform. And if you're going to do this, you have also to govern this in terms of performance and assessment. And the best way to do this is having actually guidelines, which are usually and typically managed by societies who are actually key player in stroke treatment. And talking about proctorship training, there will be requirements, basic requirements. The basic requirements is how to select the best proctors and how to select the best trainee. And if you're gonna do this as well, you also have to keep in mind that you need to assess the competency on both ends in order to generate such helpful professional workforce for the EVT procedures. If we look at the proctors, then we would say, how could we bring quality proctors in the play of training? And number one, of course, they need to have a basic certification, plus they have to be actively privileged to perform a stroke. And with that, they also have to have specifically adequate number of patients experience and more than CME training and knowledge acquiring, in my opinion, measuring outcome and looking at the record of a proctor will be more valuable in involving him in the treatment and the training of the younger professionals. Now, if we look at the proctorship options, how to get a proctor, now it depends on whether you are going to basically a proctor and a general radiology interventionist in a remote area, in which you will involve an expert traveling proctor who can cover multiple areas at the same time. And if you are working on training non-neuro interventionist in a city, then you will look at generating and formulating a group of proctors that would look after the training requirements and will take it forward. Now, in terms of training methods, there are 3 main training methods that you could involve. At the beginning, probably the notion of observe 10 and do 1 would work, because most people actually learn a lot, big deal, from just observing and shadowing an expert, a proctor who going to basically teach them how to do it. And nowadays, in the last few years, we have seen a lot of simulators coming for simulators used for thrombectomy and have been exhibited in the conferences. Most of you guys have attended. You see it in the corners in the exhibits, and you see it in the workshops. And that's something really effective in training, especially the young or the general interventionists who don't have neuro-focused training. Now, the best mode of a treatment, of course, to train somebody is to get their hands wet on the procedure table. Nothing beats that. In terms of training requirements, they basically will be 2 types of requirements: the cognitive, the educational, the academic, the basics knowledge, and the second one is a procedural one. If we talk about the cognitive, then a basic understanding and certification of the NIH stroke scale, that would be mandatory for anybody who wants to move into the pathway of training of EVT. Then the basic requirement, the second basic requirement will be 6 months documented neuroscience training in stroke and neurovascular disorders, stroke-specific training, stroke-specific examination, and evaluation of imaging criteria that will be a must to have. It's really critical for a trainee to differentiate and to learn how to differentiate between acute and chronic ischemic lesions, because that have a lot of big impact on decision making in these cases, which is time sensitive. Recognizing etiology is really critical, because that will also allow you to choose the right method of treatment. Having knowledge of perfusion imaging will also help you as a trainee to make sure you select the right patients for the right procedure in the right time. And of course, knowing the pharmacologics will help you promoting a better outcome in your patients, because that's really a must to have. And most importantly, if you're going to do something, you're going to have complications. And the only people who don't have complications, people who do not work. And if you have complications, then you have to be ready to manage them. Now, understanding the peri-procedural hemodynamics is really critical in delivering an optimum patient care. And one of the things that been suggested by most of the societies in literature is to have a minimum of observership of 20 cerebrovascular thrombectomy procedures. Talking about imaging, mastering imaging, there are basic requirements needed for the non-neurologist interventionist to master. She should be able to interpret a number of CTAs, MRAs, perfusion examinations on both CT and MR, and as well as interpreting a set number of cerebrovascular angiograms, understanding of which is really critical. In terms of a procedural experience for a trainee, he should achieve something like around 200 catheterizations, and that includes some basic angiographic procedures, microcatheter angiograms. The other 50s will split between 10 procedures in head and neck, 10 carotid bifurcation, revascularization, and 30 thrombectomy procedures. Now, in terms of choosing trainee, the best trainee are the freshly grad IR, DR residents, and IR fellows would be the most ideal because they are young, ambitious, and can be trained to get their hand wet on EVT. Of course, there's basic requirements, standard requirements, like any other practices. You have to have certification in residency, board radiology, completion of IR fellowship is a must-have that will give you the basic catheter mastering. And neuroscience training has to be done. That can be done through different modes of training. It can be done like course-based lecturing, rotations, what have you. And then also you need to get the trainee passing an assessment of mastery of cognitive skills that we mentioned earlier. NIH stroke scale certification is essential. Observing, as we said previously, basic number of thrombectomy procedures is really a must, and then completing the interpretation of set of exams. The second recruits would be a practicing interventional radiologist who is interested, motivated to help with stroke interventions, but they need to be brought to a level where they can manage stroke patients. And of course, the requirements we discussed earlier for residents and fellows would apply to practicing interventional radiologists, except an extensive experience of the general radiologist, interventional radiologist with basic catheter thrombectomy catheter skills would replace the need for residency requirements. In terms of responsibility, the main responsibility of proctor who train the residents or the fellows or the general interventional radiologist would be evaluating their competency and making sure they are completely competent and completely independent to manage these patients. And maintenance of competence once they come into the flow of a platform of managing these patients and getting privileged by the responsible board in the hospital, tertiary care hospital, then they will be a requirement to maintain their competence. And maintaining the competence would require doing minimum number of cases suggested at 10 to 20 procedures per year. To keep that competency at the expected and acceptable level. Now, institutional readiness, if you're going to start a training program in any region, including our region, that would mandate two things. First and foremost, having a full setup of interventional suite where you have the full backup needed. And then you need also the MDT stroke team that basically comprise a lot of subspecialties listed here. And that can be done now with the help of technology, can be done remotely. So that shouldn't handicap your training motivation to bring a training program into your hospital and generate more workforces. Now, one of the things that we are missing in our region is having registry. And I think having registry to central registry for the MENA to assess the EVT outcome would be really nice to see how deficient and how strong we are, and to assist the existing workforce, as well as to encourage pulling in more trained personnel into the workforce of EVT management. and also patient safety comes with that, because part of things, if you're gonna basically involve more neuroradiologists and neurointerventionists into the pool, then you need to also manage the safety for basically the early recruits and keep eye on this. And having registry is really critical. Now, I hope this talk excites on the other end some motivation for people to pay attention to the neighbors that we started on the first slide. Look at the interventionists who are interested, attracting them, training them, and getting more workforce will eventually help saving lives. And by this, I conclude. Thank you, everyone, for listening. Thank you, Dr. Abdullah and Dr. Suhail.
Thank you, Dr. Saif. Amazing as usual. When I was listening to this presentation and the way that you put all the guidelines and the requirement to establish a training program, I start to scratch my head. Dr. Saif al-Zaabi, he need to go back and to be a director of a training program for an intervention center. So I'm not sure where's that in your future plan, Saif al-Zaabi, but it's very clear that the speaker that we had today, our audience is having a huge interest in education. He's a master in admin business. He knows what he is looking to do, and I'm very happy to have you today with us, Dr. Saif. I have a question, Saif. Before I give the mic to our co-chair, Dr. Abdullah Alsalti. Why we don't have a good number of training center for the intervention in general and neurointervention specific? There's only, as far as I know, 1 or 2 centers in Saudi Arabia. I'm not sure if there's any other center at the level of the GCC. And I think there's 1 or 2 in Egypt. That's the whole region. Iran, they have 2 centers in Iran. Turkey, they have around 8 or 9. But in the GCC country, we don't have that much, neither are aboard. Saif, any reason?
Yeah, I totally agree. I think it has to come with population and also people in the leadership and also availability of resources. You are absolutely correct. The largest centers of fellowship training in interventional radiology is in Saudi. And these programs started actually long ago and generated a lot of fellows who are currently practicing in the front line. I was privileged to be a founder of the Eastern Province Interventional Radiology along with my colleagues there. We started the program about now 8-9 years back, and we generated over 10 fellows from that program. Eastern Province serving around 4 million population. And we had a lot of nice recruits. We had actually residents applying from all over the Saudi. And we get people actually from Eastern Province as well, who we trained. And the reason we don't have training, as I said, I mean, multiple factors. And for the society, and maybe if you put a program and construct a board for the society to come up and to lead into encouraging general radiologists to come. It's unfair to have 1 in 20 interventionists who are capable of getting the treatment done for these patients. It's really life-saving. You cannot manage the whole city with 1 neurointerventionist or a general interventionist with an interest in EVT. So yeah, I mean, the training in Saudi is big, and I also admire actually the Turkish for establishing a huge program. We always don't pay attention to Turkey, but Turkey have a great number of interventionists there, and I actually encountered a few of them. Amazing work, really amazing work. And
how Turkey Saif? I was looking to go and visit them to learn from them. It's a big country. It's 90 million, 80 million population, but unfortunate major or large scale country, Arab country, they don't have that number of centers, neither interventionists. Why is that?
Well, there is a major difference in leadership in Turkey. I met with a few interventionists. The amount of support they get is really huge, and they use what we use. They use branded intervention tools. They have access to for resources. And it's a populated country, of course, and with population comes cases, and they work hard. And to everyone here listening to this talk, I'm going to give you a hint. If you want to train in a skill, go to Turkey. But the Turkey system is easier than any other system where you can get access to training and you can do magnificent. And this is a hint. Because myself, I did go to master a specific skill in a specific procedure, and I could not find a better place to train more than where you can put your hand immediately on cases and safely, because the interventionists you work with, they won't let you, of course, work unless they know who you are. But it is actually, this opens doors to collaborate with the Turkish universities specifically, and general hospitals of Ministry of Health, to train people there, and they have the training platform, by the way. So if that's something interest people here in the region, I would love to collaborate and help getting dots connected.
Dr. Abdullah, please.
Thanks, Dr. Saif, for this nice talk. Since Dr. Ali, he's not, I think he's get excused because he's had some emergency or committed, and he's also on call today also for the intervention. So as you know, the Dr. Saif, the interventionist, can be called at any time. So may we guide all the question to our pioneer here, Dr. Saif, and also our Prof stroke specialist, Dr. also Suhail, can add on that part too. So Dr. Ali, he mentioned in his talk the sensitivity of the imaging for carotid, especially for the carotid dissection. What I'm surprised actually with the low sensitivity, especially for the CT angio, range to almost like 60 to like 95 or 90. And also to MRI, the wide range on the sensitivity. To reach even the MRA, for example, to 20%, up to 90%, for example, the sensitivity of the carotid dissection. Did that, Dr. Saif, as a protocol, if we really suspect high suspicious of dissection, we should not rely on only one image from your perspective. Can we, for example, do carotid, for example, Doppler, in addition to also, because as you know, the Doppler can measure the velocity, has some sensitivities or more sensitivity in certain part of the blood flow, whereas the CT angio more, for example, for the structural part, more sensitive on that part. So did you recommend two more image rather than relying only on one image because of the wide range of sensitivity?
Well, honestly, I have to look into literature on this, but I could give you the basics. Now, it depends where you are encountering dissection. Is the dissection extracranial or is that intracranial? Okay. And that dictates your mode of imaging, because the only people who can see the carotid artery really nice are the little babies, where you can put your ultrasound Doppler and see the inside of it. But for adult, where we see and encounter most of carotid dissections, you will not be able to use ultrasound for intracranial, but sure, you can actually beautifully see the dissection on a good day on a good machine in the extracranial segment. And CTA and MRA are two different modalities. And nothing beats CTA in vascular imaging, especially with the newer machines. Now, I do have doubts on these statistics, because most of these statistics are read with an old generation. Now, statistics that we read and published like this year actually are accumulative of probably 10 years ago or 5 years ago, at least, where the machines are not as good as today. Today, we have a better dual scan imaging, CTAs. We have really quicker scans. They do it in a fraction of seconds, and they can give you the beautiful vasculature. The only problem with imaging, the sensitivity, is the quality of imaging catching that vessel in the systole or diastole still. And if you if you image them in between, that pulsation artifact will actually deceive you. That's why it will drop the sensitivity. It's all about machines. I was visiting one of the hospitals in Dubai Healthcare City and was amazed by the quality they are putting there. And Dr. Suhail knows what I talk about. They have beautiful CT there, and you know, because we're not doing marketing hospitals, but I'm just talking that they have really state-of-art a machine that does this. In a second, you can get the carotid image. The sensitivity is really superb. So again, it depends on what you are dealing with. A single modality, of course, Dr. Abdullah, I mean, the double modality would help you where you have doubt on one, no question, but MRA tends to overestimate disease. So I don't trust MRA. MRA has value where you have vasculitis type of occlusion or partial occlusion of the carotid, like the chiaso and other things, and angiitis of vasculitis, and you could see actually the inflamed wall and you could measure the thickness. That's the beauty of MRI. But if you're going to do that, you have to do it gated with the ECG so you can get better results.
And this is what Saif is mentioning here regarding the fast suppression double wall imaging that we are doing for looking for the wall abnormality, Abdullah, on the MRA, that you can see it and to distinguish if this is vasculitis, is this a dissection of M1, M2, is this atherosclerotic disease. Nowadays, the new devices, MRA with a new technique that they're using, you can help and differentiate different types.
Yeah, thank you. That's clear, Dr. Saif. So we'll have some questions from the audience. There is a question actually in regard to Dr. Saif, or if he can kindly elaborate on this. Treatment of cervical carotid dissection, which is an extracranial, in a patient with a traumatic brain injury on the contralateral side with brain contusion. How you will deal with that? Multiple contusion on the contralateral side.
Well, I usually, actually, I'm not involved in emergency treatment of carotid to answer this question. But, you know, it depends on the extent of any dissection. I'm talking general here. It depends on whether you have a stroke with it or not. The decision will be obviously different, because the reason we put stent, for example, is to establish flow. And you will establish flow if there is good prognosis on a case, depending which vessel you are open. I'm just giving general because I don't treat these cases, honestly. And I do put the carotid stenting for other categories, but not for traumatic per se. And I will leave it probably to Dr. Ali to answer it. But that would be my way to handle this. If I'm faced with it, carotid stenting will be placed if I feel this will benefit the patient, establish flow, and I will revive the brain, and probably perfusion study before that would basically help me to guide me towards, you know, whether I do it or not.
Yeah, thank you, Dr. Saif. Also, Dr. Ali put his email that he's happy to be contacted through email for any question also about his talk. Also, there's another questions actually. For example, all the intracarotid dissection with the recovery. For example, patient presented now with left side amaurosis fugax, for example, but there's another history of like resembling of amaurosis fugax almost recovered on the right eye vision without other symptoms, for example, retrospectively 1 year back. But when you image the patient this year, you found that really there's a right intracarotid dissection with aneurysm, if I understand the question correctly. So how you correct asymptomatic? Now we can almost call it like asymptomatic old intracarotid dissection, like 1 year back. You will do the same like for the acute setting, Dr. Saif?
Well, I would give you my experience with the aortic injuries where I've been involved with, and probably you could infer some answers towards this, because again, I'm not a neurointerventionist. I don't treat trauma, but in the neck and head, and maybe there are some different rules, there are guidelines. I have to check on this honestly. I don't want to deceive audience here. But for aortic, we've been involved with traumatic injuries into the aorta with pseudoaneurysm formed. And we found actually the best to deal with this in young patients is to observe, because if you put stent for this, if you're a young patient, then they will grow with a stricture in the vessel. So there is the cutoff we made in our institute, 18 years, is where we kind put a stent, because basically the vessel size is almost mature. And we always try to refrain from putting these for smaller aneurysm, sub-centimeter. We don't actually treat them, we leave them. And we have the courage of these cases. We have actually case record on this where we observed them, and that was aortoiliac for different reasons, most of them traumatic, by the way. And we found conservative therapy for smaller ones works really beautifully well. But if it is bigger and there is a threatening or rebleed, then you have to put stent. And if it is younger than 18 years, then specifically less than 12 years, sometimes 12 to 18 gray zone, because you find actually a bigger size, young patients. So the decision is based on your assessment there, but we send them to surgery, honestly, because we don't want to put stent in younger patients. But the answer, again, the answer to the carotid one, I would actually leave it to the experts to answer it.
Yes, so also I will leave now the microphone to Dr. Saif if you have also another question, Dr. Saif.
Suhail.
Dr. Suhail, I mean Dr. Suhail, Prof. Saif.
Suhail, Saif, it's pronounced the same. I have a question from Dr. Mohammed Asghar Khan. He asked very important questions. How many intervention cardiologists is there in Oman, approximate, Dr. Saif Zaabi?
Well, most of them working in the government. So Abdullah, we have to answer me and you, I think, because you are
approximate. How many? How many approximate?
In cardiology, there is actually handful. I think in the university, I know there are 3 or 4, and in Royal,
more I don't know. Around 10 or more. We have a lot in private also. We have you mean cardiac interventionist, yeah?
Yes, cardiac interventionist.
Cardiac intervention, we have a lot. Yeah, and we have good enough numbers. We have good.
In a city like Dubai, we have almost definitely more than 25 cardiac interventionists. Okay, yes. So the question that Dr. Mohammed Asghar Khan said, do you recommend interventional cardiologists to do the endovascular treatment for acute stroke, as there is a deficiency of neurointervention everywhere? Saif.
I think that's really excellent question. I like the question, and that falls under category 2 of training proposed by the American and European Society. The slides I brought to you guys was actually from recommendation from both European and American societies. And the recommendation here for non-neuro, a cardiologist would fall in non-neuro and has catheter skills that allow them to do procedures as far as they go through the training simulation and fulfill the basic requirements of neuroscience training and interpretation. Interpretation is not really difficult. You could do it in a course of 1 week. You just need to shower the cases on somebody and train them through a course, and you could fulfill the requirements. So my answer, yes. And that would be really nice.
So that what you mentioned, Dr. Zaabi, about 6 months of training, is that for a intervention cardiologist, for a neuroradiologist who didn't do an intervention? When you said 6 months is enough to do 20 cases, that was a small or short period, Saif.
Yeah, I mean, it is all about it, who are getting selected for training or who is being promoted in the training. And 6 months is a number suggested to accommodate training the neuroscience segments of clinical imaging, clinical examination, clinical basic understanding of clinical in stroke. And that applies to everyone, because unless you understand these, then you will not be able to do it. In 6 months, it's not rigid. I think can be shortened with intense programs. But if you're going to basically involve practicing physician, either in private or government, they are overwhelmed with their work. So that the amount of time you have is going to be tailored to their part-time availability. And 6 months is not really rigid, can be modified. I think the target is to achieve those numbers, not actually the time frame.
And that what the German group in the German Neurointervention Society, they are doing. They are designing a new program that will be mainly for strokologists, they will call them. Okay, and these strokologists is a group of interventionists who's just dealing with the emergency stroke cases, where they need to do the suction, the stent retriever, or a small area of angioplasty or stent. They don't do the ABM, they don't do the calling, they don't do the rupture aneurysm, they don't only doing an acute stroke, and they will call them a strokeologist. I believe having more of these young strokeologists in a city like Dubai, having 3-4 centers. Currently, we have 2 centers who's delivering 24/7. In one center, we have 3 interventionists, neurointerventionists. In the other center, we have 2 people. And that almost covering a good portion of the cases in city of Dubai. In Abu Dhabi, we have a Cleveland clinic where they have almost 4 or 5 neurointerventionists who just dedicated for that. So having a program like what Dr. Saif al-Zaabi mentioned regarding training in a short period, 6 months to 12 months, a cardiologist who's doing intervention, or a radiologist who's interested to do this and doing only a life-saving procedure like acute stroke, that will be an asset for any city. What do you think, Saif?
Yeah, no doubt, because you see a lot of patients hitting the emergency, and if you have one neurointerventionist or a non-neurointerventionist who do stroke and they are away, they are physicians, they are humans, they're going to take leaves, they're not going to be available 24/7, and of course having more hands will save lives, and this is really serious now with the growing population, growing number of cases on the record. That makes this really mandatory. And who will do this? I mean, this group here in this platform are more in the front line of taking decisions and taking the motives forward. And I wish that comes to a program that we could see from your prestigious society coming up to see the light here under the MENA area.
Inshallah. So before we end it, it was a nice talk today. Today, around between 1:30 to 2:30, Dr. Naseeb, who's our stroke coordinator in Rashid Hospital, he's running every 2 weeks our grand round of stroke and cerebrovascular disease. Today in Rashid Hospital, our 2 junior residents, Dr. Sheikha and Dr. Ali, R2. They are doing the grand round. Dr. Abdullah Alsalti presenting the 2 challenge cases that we had over the last 2 weeks with the acute stroke thrombectomy. One of them has been stented, the other one had bled. So this is presented by our junior doctors who's running the stroke code, and we have a template that describing every 2 weeks how many patients has been TPA, how many patients went for a thrombectomy. In one of the months, I believe it was in September, we had in 2 weeks around 9 cases. So every second day there's 1 case of acute thrombectomy. One day, just last week, we had 2 at the same time on the table. And alhamdulillah, we had 2 angio suite for the neurointervention, and they went at the same time, Abdullah. I receive a good message from Dr. Zaabi tonight, audience, that there's a huge demand to build a training center at the level of the region. And there's a good country that they're ahead of other country that we can use them to train our junior doctors to cover that area where maybe we are late or behind the other countries in building our capacity in this. Abdullah Salti.
Yes, I totally agree with you, Dr. The city like Dubai of population, the number of this is demand, especially when you have now, for example, 2 cases which really require thrombectomy to be done. The good things with Dubai also, the situation from city to city is slightly different, and region. For example, the approach in Oman, for example, we have different cities which is far away from, it need at least 2 hours to reach to the city if you really want to gather all the intervention in one city, for example. Whereas Dubai, for example, they are all clustered in the same area, so they can reach to the available centers with intervention in a minute, in a few minutes, like 15 to 20 minutes, they are in the hospital, having the successful intervention very close. So I agree with you. However, the situation slightly differ from countries to countries. For example, if we talk about, for example, Muscat, which is around a million or close to the million population, whereas Dubai is more like, for example, 4 or 5 times or even higher, double times. So in that case, the intervention is available by population slightly different. So we are really, we do, for example, interventionist, maybe close to you in a day. What you do in a day, we might do it in a week. For example, we 2 to 3 cases, 4 cases. Sometimes we reach even 3 to 4 cases. Sometimes we do 2 cases in the same day, like interventionist. The good things when you have 2 to 3 interventionists in one center, you will create a competitive, because if each one he want to have a credit to numbers of patients rather than you have only 1 or 2. So it is not really. Sometimes we'll take it. People say we have a lot of interventionists, but the number of cases is not enough in order to have 2 or 3 interventionists, the available interventionists in the same centers. But what I felt it really, it will be more enthusiastic, more competitive, and the benefit also, the service will improve more and more when you have different. As you said today, you have ground round discussion with 2 or 3 interventionists, stroke specialists, a lot of people. So an add-on on the management will be more in such cases. Thanks, Suhail.
Great. And part of this, if Dr. Saif will agree with this, is to train the EMS service where to take these patients in the field who presented with acute stroke. So if they are well trained, the EMS, الإسعاف, they will take the patients to the right hospital where they will get the right stroke unit, right intervention, right treatment. And this is for a city like Oman, like Dubai, like Riyadh. That's very crucial and important. They don't go to the small or a big hospital that they don't have an interventionist or a stroke unit, that there's no value. At the end, I would like to conclude this webinar. It was my honor to be co-chair this with Dr. Abdullah Alsalti. It's honor to have Dr. Saif al-Zaabi being with us today. Dr. Saif enlightened us about the importance of building a stroke system, of training stroke, and how we can prevent stroke by having these type of center. Then we had our other speaker, Dr. Ali Al-Balushi, who spoke about a rare condition of stroke, which is a dissection. Young patient, usually we missed these patients with a dissection if we don't think about it. He spoke about update in managing these conditions, how to treat it, and the prognostic of these patients and recurrent of dissection. Our audience, it was a great night that we had all of you today with us. We had a great number of participants tonight, and this webinar will be recorded and uploaded on the MENASO YouTube channel within a period of 2 weeks. Then also you will get your CME within 2 weeks from today. Dr. Saif al-Zaabi, Jazakallah khair for being with us tonight.
بارك الله فيك دكتورنا. شكرا على الدعوة. Thank you so much.
إذا جيت كلمني دبي, you have my mobile, please. I need your help. And thanks for Dr. Abdullah Alsalti for being with us today. Salam alaikum, Dr.
حياكم الله. شكرا.
Thank you so much, Dr.